Good afternoon, chairpersons, colleagues and friends. Thank you, Team Vezomeg, for the invitation and opportunity. I would share my little experience about vessel preparations for DCB. And all these things, what we will see in the slides, are very new to the most of us practice. This is a very common algorithm most of us have for FEMPOP angioplasty. All of us predilate, and as Chaitanya said, if you're happy with predilatation, only POBA, and then probably the case is over. But the evidence says, there's a lot of evidence now that only POBA versus DCB. DCB fares much better, as Robbie said, for a long-term outcome. So we go ahead with DCB for 3 minutes. And again, if you find a dissection, depending upon the type of calcium burden, you can decide whether you need to go for some kind of technology or again dilate, and if need be, put a small, very thin wall stent. If you find to begin with, I'll show you one of these cases, a slide we did recently. If there's a very heavy concentric calcification, and probably that you cannot take care of with any kind of balloon, then you have two options. Either use some device like atherectomies to debulk that, to have some kind of a luminal gain, or else you can straight away go with vasculomimetic stent. So this is how kind of, all of us practice FEMPOP angioplasty. And those all of us are into practice for years have seen that these are the outcomes of angioplasty. Plenty of literature saying that primary patency is 70% at 1 year. When you read this, the primary patency of DCB is also somewhere 85 to 90% at 1 year. ISR is very huge range, you see 9 to 37%. Stent occlusion is 7.5 at 1 year and 15 at 2 years. And these are the caveats. These are the factors which decides the outcome of stenting. Length of lesion, more than 15 centimeter, more than one stent, CTO, long CTOs, female gender, probably due to small size blood vessels, task C and D lesions, and this one, plaque burden more than 60% after doing an angioplasty. Look at this slide. You see nearly more than half of this lumen, you still see a lot of calcium. So this type of lesion, if you do angioplasty, I'm sure they will not hold for a long time. And this is what Rohit had a question in mind, that how do you convince your patient to put a stent or to put a balloon? Keep some pictures like this, show them occluded stents. Ultimately, it is your belief. You have to get convinced first what works for your practice. Is stent, POBA, DB, atherectomy? So you have to have experience based on the science, and then you can take a call. How should you? The pendulum is in your hand, the way you sway it. So this meta-analysis of more than 8 RCTs and data, they have shown that DCB certainly fares much better over POBA. We all of us agree to that. And again, there is a lot of evidence about vessel preparation. That was my talk. And these are the objectives. We need to have some kind of vessel preparations to have an adequate luminal gain. At times CTO, you just balloon, and how can you expect a rubber to take care of a rock solid calcium? It cannot. So you should have some kind of luminal gain. You also do something so that long lesions, you can take care of dissections, again, flow limiting dissections. By doing any technology, use any method, you have to change the plaque, you have to change the vessel compliance. And many studies have shown that calcium is a barrier for drug absorption. So you cannot have a very calcified vessel and just inflating a balloon where drug does not get into the media, where you can prevent SMC proliferation. So these are the objectives. And again, a lot of evidence. And this Fenali study have shown kind of a calcium we have, 1 quarter, 2 quarter, 3 quarters, and all quarters. Look at this. This is a very common picture, one of our practice. This type of calcium, if you do whatever kind of stent, I think this stent won't open up completely. And this is again data that leaves when you do an angioplasty in 2 projections, look at this one AP and oblique one. More than half of the stent, the lumen is still covered with calcium. So in such cases, not in all cases, in such cases when the calcium burden is more, when you need drug to get into the tunica media, probably you do some kind of vessel preparations. And these are the tools we have today for vessel preparations. We have a whole lot of different balloons, plain balloon, high pressure balloons, non-compliant, semi-compliant, cutting balloons, chocolate balloons, IVL balloons. We have a lot of, we are familiar with IVL balloons and non-compliant balloons. We used to use cutting balloons for fistula angioplasties. We won't use it much for FEMPOP angioplasties, and these are the atherectomies. We used to use directional atherectomies like Hawk devices when they were introduced some years ago. No longer rotational devices, orbital and laser. All these devices have come. Last year, probably all the companies have come into the market with different kind of devices. Jetstream, this Diamond Stealth from Abbott, Hawk from Medtronics. This is a Spectranetics lasers, and also from BD, this Rotarex or Aspirex. And these are the different kind of qualities of these machines, all these devices have. When you have a pure calcium, probably you need to have some kind of atherectomy devices. Hawk, we used to use Hawk. I don't have an experience of either Jetstream or a Stealth yet to use them. But we have a lot of technology available to use different kind of atherectomy, provided you have a case with a very heavy calcium burden. And this is the evidence. The next speaker is going to talk about the evidence and trials. There's a two, though very small sample size. I don't see a huge sample size, less than 50, around 50 cases. It's not something you derive on the day-to-day practice. We do hundreds of cases. But still, all of these studies have shown, and it is a common sense. When you can debulk the tumor, probably you will have, better primary patency and less freedom from TMR will be higher. Again, we have different kinds of balloons, IVL balloons, scoring balloons, angioscalp balloons, and chocolate balloons. All the balloons again have shown that if you use this, basically all these balloons, they create a way, scoring or cutting or IVL, they break the calcium and fibrous tissues so that they make a way for drug to penetrate, and the long-term results are much better. And they have shown in those small numbers, where chocolate balloons, a large number study, and they have shown all these criteria like primary patency, freedom from TLR, or freedom from major amputations were much better. So there's enough evidence to tell your patients also that, look, the science is this. Now the dilemma in our mind, how to choose it. Very simple. If you have a very calcified lesion, concentric or eccentric, you need to have some kind of atherectomy device. If you have eccentric calcium, you can pick it up. I think Hawk devices are much better. If you have concentric calcification all around, probably rotational or this device is much better. And a mix where the calcium and this thing, probably you can have rotational and aspiration, like orbital devices are much better in those cases. When you have long fibrotic lesions in a small diameter artery, especially in women, osteal lesions or bifurcation lesions, if you use some kind of devices, that they could be plaque shift embolizations. So in those cases, some kind of balloon like IVL, chocolate, scoring balloon or cutting balloon is much advocated. This again a good paper. They said the procedural criteria, you should be these are very important to have a good preparation, a good long-term outcome. Less than 20% diameter stenosis at the end of whatever device you use, balloon or atherectomy or aspirations. Prolonged time for more than 3 minutes, and BSR has to be 0.9 or less. And this was again a study about the inflation time. Who have time? All of us are so, in haste, a lot of cases to do. 2 minutes of pre-dilators in a smaller size balloon. This is what is, we have to understand, that you shouldn't go to the rest RBP or NBP. You have to have an opening pressure. If the lesion opens at 4 or 5 or 6, don't go to 8. They say, and the pre-dilatation has to be a smaller balloon. If a vessel is 6 probably or 5, use 4 millimeter balloon to pre-dilate. Then 3-minute pressures with low pressure, DCB 1:1. So what we do, we normally measure on a sonography the size, the diameter of SFA, and looking at the diameter of SFA on ultrasound, we decide the size of DCB we use. And even after this, if you find some dissection, you again dilate for 3 more minutes, and you might see the dissection, it gets stuck to the wall, and you don't have to put any kind of bailout stents. These studies also showed that recommended low pressure prolonged dilatation, no difference in the residual stenosis, not a long-term outcome, but it did not worsen kind of a dissection. So we have to be very careful about it, that we should give enough time for balloon dilatation. Not just 1 minute, it should have a couple of minutes. So I normally, if very resistant lesion, I go for 5 minutes and more also. One of the cases we did last week was these days, because all of us who are doing angioplasties, femoral angioplasties, all of our patients have come back with using longer stents. And everybody must have had this experience, and we are also learning new things. So this was a guy, very typical lesions, so very ideal case, had multi-level lesions of short segment, lower SFA, popliteal, tibial lesions. I couldn't get the picture of a predilation here. The small size balloon was used, 4 millimeter, and then long 6 millimeter. This was paclitaxial use balloon, mosaic PB was used, and this was normal POBA. So far is doing good, no acute problems. Another case, 65-year-old gentleman, PTCA, diabetic, hypertensive, very short distance claudication pain. He and when look at this picture, only on looking at the angiogram, we have a lot of calcium burden. And we have to use something, not only POBA will work in this case to begin with. And this is a DSA, you see a lot of calcium, the long segment lesion. No wonder, no debate about FAMPA bypass. We are not here to discuss about bypass or angioplasty. We did angioplasty somehow, and you see this, look at the calcium burden, and despite using semi-compliant or non-compliant balloon, we went close to RBP, but this was very stubborn calcium, no wonder. We couldn't open it up. We took pictures in different projections. You see AP, LAO, right, left LAO, and just to make sure that how much calcium is there. These are the cases, ideal cases, where we need some kind of atherectomy devices. We do not have a good experience in the devices. So what I did a kind of a spot stenting here, use a vasculomimetic stent there in this area, and the proximal one is DCB, and this was the final outcome. So to summarize, vessel preparation has progressed from fiction to fact. Many of us are practicing in our routine practice. It is an integral part of endovascular practices. It will become a part of an algorithms. It is important, very important key step to optimize acute outcomes, like to prevent dissections, to facilitate drug delivery into the lesions, and to bring better long-term outcomes. Thank you very much, ladies and gentlemen.